talk and by Dr. Santosh Gopi Krishna, who is a consultant in Bangalore. He's going to present his challenging case. Yeah, please, over to you, Santosh.
Uh, Thank you, sir. My slides are seen.
Yeah, yes, please carry on.
Yes, yes. Uh, Good morning. I would like to thank AOS and Alcon for this opportunity. So I'll be presenting a few challenging cases that we routinely do. So this is a 60-year-old lady, type 2 diabetes and hypertension. Right eye, she had undergone vitrectomy for vitreous hemorrhage and TID. Elsewhere, silicone oil, you can see the outer retinal breaks here, listed retina and the taut retina. So just left alone. So she came with the left eye TID with just a small frill of outer retina that's holding the fovea back, and we can see the traction here, the macular TID. Why I chose this case is because of this. There was hilar detachment in the temporal periphery till here, but from here it was flatly attached, and here it's not very clear. But once I gave an anti-VEGF, the fibrovascular proliferation got quite clearer. They were almost till mid periphery and beyond. So this was the case. So usually I use one non-oval cannula for ease of the blood coming out and ease of the surgery. So after the initial truncation, the temporal hilar, which was already detached. So I went to the posterior pole, and you can see the membranes that were there. This 4x speed, what I've kind of for the ease of showing things. So since there was a pre-macular membrane, I was trying to kind of isolate the membrane. So I was not cutting. I was just trying to have a feel of what was there. Then usually what I do is I secure the macula and the fovea, and then I secure the disc so that there is no disc bleed, because it's very difficult to manage. So, and since there's a nasal polyp, I had some bad experiences earlier on when I started off doing surgeries. These nasal polyps, obviously the nasal retina is very thinned out. If not properly dissected, they can cause break, and anterior if it's still there, it can cause a recurrent retinal detachment, and we can lose eye. So this is how I started. Usually I kind of lift and shave, and then I kind of segmented these pieces. And after that, like again, I went back to the other proliferation that was there. You can see these white lines that were there along the blood vessels. Obviously, these are very thinned out retinas. And what I personally felt was whenever I try to kind of detect these things, they cause linear breaks and again retinal detachments. So the problem is, even when I use a non-vial cannula, the risk of the retina getting bullous is very high. So that's one demerit what with the non-vial cannulas maybe. So this is how I went about. Like I tried separating these membranes from the anterior hilar piece and the thick flat polyps. So then there was a bleed in between. The moment I removed the instrument from the right port, then the blood kind of went off, and then I could easily go and cauterize these things. So I came for the anterior approach again, wherever I found the gap here. So you can see the membranes easily kind of getting dissected. Now the problem comes is the anterior hilar proliferation. Now here I went in the core mode. Earlier it was in the shave. So I tried to kind of induce a PVD with a little bit of suction, try to get a hold of the gap between retina, and also I went around, and then you can see the linear break forming in spite of using minimal force. So it was just the initial suction wherein I tried to separate the hyaloid, and then I started cutting the membranes. Here I had cut the membrane into half, so I dissected it so that when I saw the break forming here, then again kind of the membrane dissection. I do a lot of cautery. I don't hesitate. And now coming to the posterior pole, so I could see the frill of retinal tissue here. So I did a fovea sparing ILM peeling, because there was not a though there was a small thin film of outer retina. I thought better not to tuck in, hopefully thinking that it's not a full thickness macular hole. So I was careful again with the shave mode, and try to kind of did a fovea sparing ILM. And this was a break wherein I dried and laser and then oil. So yeah, so this was post 1 week follow-up. You could see it turned out to be a full thickness macular hole. Just hoping for the macula to settle and see how it really behaves, whether it's a type 2 and all. Maybe I can do a ILM transplant later. So the vision is 636. The issue is being the one-eyed patient again. So coming to a second case, this is a 34-year-old young lady, type 1 diabetes. Right eye, counting finger close to it, you can see a thick fibrovascular proliferation at the macula. It's like a pucker like kind of a thing. Left eye lasered, very well lasered, but you can see a taut highlight. subhilar hemorrhage and vitreous hemorrhage. So not much could be imaged to the OCT here. But left eye OCT seemed okay, but the vision strangely was 624. There was some amount of PAC there. So this, after initial truncation, this was a different kind of a scenario where the highlight was completely separated. So somehow I am a big fan of just the cutter alone, with all due respect to bimanual techniques and forceps and all. So as already highlighted by panelists and the speakers. So I mean, I usually use cutter quite a lot. I mean, maybe lazy to use the chandelier and other things. So you could see segmenting lift and shape, and the problem is the folds that were there under the fibrous proliferation. So proper delamination, that was, I mean, proper finding the plane was extremely important. There were second membranes, so I was trying to catch hold of the second membranes and trying to isolate these. So this is the disc, this is the macula. So the best part again, where I found the use of non-wall cannula in this case was like the bleed which was there, the moment it goes, it meant minimum instrument exchange, and then that's how I keep doing it. So again, tackling the fibroscope proliferation separately, each one. So there was a thick retinal fold because of the long-standing traction here. So you can see the membrane totally coming off piece by piece. There was a second membrane that was running here from here to the inferior arcade, that also I kind of separated. Again, this is 4x speed. And this was a connection from the disc to the nasal retinal fold. So I tried to kind of come from one side, and then I kind of went linear along the retinal folds. So then I could dissect it better. So just a fold back, then it just comes off. Again, now the final part is a disc that is attached to the retinal fold here. So I tried isolating from one side. So usually I don't use suction when I'm trying to kind of get into the groove. So it's just that the blunt dissection what I usually use, and I tend to leave a stump at the disc and finally cauterize it, because I had some tough time controlling a disc bleed. A fairly good surgery which went bad because of the disc bleed. So usually I leave a stump. I see that there's no attachment of the stump to in and around the retinal surface. So I kind of move my cutter all around, and being the bevel cutter what it is. So it's really easy to kind of get under the polyp and the retina, and you can really isolate this, and you can just cauterize and leave it. So that's how it kind of, and you show that it won't pull the retina later on. Okay, so cautery again. Then, as I told, like the problem with the non-wall cannula, the retina getting bullous, then I had to make a drainage retinotomy. And the laser and the oil and close. So this was a post-op course. 1 week later, the problem in this case was the patient, since young patient, since she had undergone a stent just 3 months back, she was on double anticoagulants. I was worried about the bleed. Luckily, so it really didn't bleed much. And so 6/18 vision 1 week later, and the macula, the fold kind of started flattening over a period of time. So this was already spoken about. So I used 27 which for a few cases, but not very complex TRDs, because I just feel like, I mean, I'm still kind of shifting from 25 to 27. So you can see a very good cutter, the vitreous coming in very nicely, and even just the suction cutter and all, even the back flush, the bleed that could be aspirated, the stump again cauterized. ILM. The best part I felt was these second membranes what were attached at the posterior pole that could be easily isolated from the surrounding retina, even without pulling or a forceps, and you can kind of bunch it up and then kind of cut and cauterize and leave it. So and this is a laser, and good control of laser, even closer to the macula and posterior pole. So this was the 27. So to wind it up, to conclude, the concerns in the first place, what I really wanted to discuss was this, and I would like to know the valuable opinions of the panel, how to go about, because these are tough cases, especially, I mean, Elevated polyps, as we all know, at the posterior pole everywhere, when there's a good highlight suppression, is really easy. But a little break here and the anterior highlight that is left over can lead to recurrent retinal detachments, and we lose the eye. So how do the panel go about? And that was a concern. And again, the coexisting almost full thickness macular hole here. So how do we manage other ways to do the nasal fat proliferations and chandelier and bimanual techniques? And whether I should have done the inverted IL, what do you call, fovea sparing ILM first place to kind of relieve the traction before even starting the nasal dissection. So thank you all for a patient listening.